people are nice enough to let me into the data that they're using and the questions that they're wondering about, and are flexible enough to sort of allow me and a group of 20 other medical students to be integrated into their teams, and try to help them out for the sort of 6 weeks that we're down here.
That's awesome. What's one of the questions that they're asking?
The questions that they're wondering about right now are, what are we ignoring broadly? And also, what are we ignoring about COVID in older adults, which is an area that's near and dear to my heart. A question that I've been asking of this huge data set, a data set which covers all hospitalized adults in the United States, is how do the rates of COVID and the rates of antiviral use look different in the group that is 75 to 89 years old versus the group that's 90 years old and above? I think we often lump all older adults into one category, when in reality, the rates of COVID mortality are much higher in those who are older than 90 than those in the 75 to 89 category. And so you'd hope that much more people 90 plus would be receiving medication to help prevent that mortality. But unfortunately, I don't think that we'll see that play out as clearly. And I think the team is curious, why is that? What are we missing about the care of these older people? And what does that say about our society's priorities for the aging world that we are coming to live in?
You're listening to Therapy for the World, an interview series with kind, thought-provoking people working along the spectrum of self-care and world care. I'm Dan, a writing therapist and teacher, and this is my conversation with Claire Quinlan, a writer, community leader, and rising voice in the medical world. We recorded this conversation in early 2024, so it's a bit outdated, but hopefully still fresh. Happy listening. So caring for older people will most likely be a theme of our yet to be determined conversation today.
Yes, got us all on the right foot.
I would love to ask you as a first question, jumping off point, Claire, what is something that you have found to be true?
Something that's true. I think I've been noticing ever since I came to Atlanta many things. One, though, is that when you give people a chance, they'll usually rise to your expectations. I find that in coming to this new city where I don't know many people, I'm staying with some friends of my parents who I don't know very well. And the trepidation of coming to a new place and coming to a new agency as enormous as the CDC, and just seeing people on the street, I feel that this year and all that's come in the news has sometimes made me feel like an optimism in humanity is misguided or short-sighted or naive. But I think coming to this brand new place shows me that, I believe in people overall, and that's proven to be correct.
There seems to be a difference between what we observe locally and globally at times.
Totally.
And mass media wise and local observation wise, where the world certainly doesn't seem to be ending in some interpersonal relationships that are rich and full of color.
Yeah, absolutely. Absolutely. I know it almost makes world events hard to believe when you see how kind people are overall. I always think of humanity in like 3 different groups. Like, how do I feel about an individual? How do I feel about a small group of people? And how do I feel about an enormous group of people? And I think I have real and genuine trust in the individual and real and genuine trust in large groups of people. My concern is when it's the middle, when it's a small group of people that might be guided by, um, you know, troublesome beliefs. Um, but I haven't figured it all out yet.
Sure. Yeah, that's so interesting to divide the world in those three groups. It makes sense. Also, I mean, it's analogous to like individual city and country, or uh, city, country, world. You know, we can find many
Yeah.
divisions like those. Why? I wonder why the middle step is the most concerning.
Well, I think of it a little bit statistically. I think of most trends and the noise evens out if you have enough groups of people. For example, if you have like a jar of M&Ms and you ask one person to guess how many M&Ms are in there, they perhaps will guess very wrong. But if you ask 100,000 people how many M&Ms are in the jar, it's remarkable. The average of all of their guesses will basically find the truth. And I think that when we are in big enough groups of people, the diversity that those big groups brings means that there is truth at the center of that team. But I'm not sure if in a small group of people, I'm not sure what it is about that size. It seems maybe easy to rally that group around something or convince them, as I know I've been convinced myself. Um,
Well, yeah, it's as though if you were to ask individuals spread out around the world how many M&Ms are in that jar, likely your response, or the aggregate response would be more accurate than if you were to ask all the individuals in a small room how many M&Ms are in that jar, and they all got to hear each other's responses, right? It's the phenomena we call groupthink sometimes, where
mhm.
we start influencing each other's responses. I can see why that might be the case. This is a,
Yes.
a very worthy metaphor. It's not surprising to me that you think this way. You have a huge background in writing and English in addition to your profession in medicine and in the world of science. You were an English lit major. You also went to college under a creative writing scholarship, and you were a reporter at the Chicago Tribune. What is this other writing side of your life? Is it active right now? How does it jive with medicine?
Hmm. Hmm. Yeah. I think the writing I have to tell you something. My grandpa, he passed away 3 years ago now. And the last time I saw him was at a Thanksgiving dinner. And my grandpa and I weren't so close. I didn't have many moments where it was just him and I connecting. But we had one of those moments at Thanksgiving dinner that night. And this was only months before he ended up passing away. And at that dinner, he looked over at me and he knew that I was in medical school. And he looked at me very carefully. And for context, my grandpa was a reporter. He worked for the Sun Times in Chicago and the Albuquerque Star Tribune and various newspapers all around the country, and moved my dad along as a little kid with him. And so I think he always thought that by choosing medical school, I was giving up this other side of myself, which I really do identify with, the side that tries to be observant and record people and try to tell their stories. And he looked over at me and he said, "If you give up writing, you will never be happy." And I remember feeling like that was the most direct piece of advice I've probably ever been given. I think the people that I surround myself with mostly, are a little bit more indirect or a little gentler in their support. And so I think that has echoed in my mind ever since that moment, because I do trust what he's saying. I think to write is to live, and to observe is to live, and to read is to live. And so I'm not willing to give any of those things up, even when medical school gets to be so busy, which is part of the reason why I went to medical school in the first place, is because I think in many areas of medicine, observing and telling people stories is the central goal. I feel
How
that
does
way,
that happen?
especially.
How does that happen in the world of medicine? Stories. What does that mean?
Yeah, I think especially as a medical student, you're often the first person to see the patient. And so the patient is describing sometimes the very worst moment of their entire life. And your goal as the medical student is often to go and talk to the real doctor and get across the urgency and the emotion, but also the objective facts of the case in a way that's going to compel that doctor to do something about it. And that's a lot of pressure. And I think ultimately a lot of medical students don't have a lot of medical knowledge. I surely don't. And I have a lot more to learn. But what I have worked on these past 4 years is how to try and capture some of the essence of what someone has told me, and then retell that in a way that conveys that same essence.
Sure. It seems to me that from what you're describing, folks come in with stories about their bodies and what occurs to them even before they speak to a doctor. And on occasion, a doctor can come to influence this story for better or for worse, right? I mean, the way a diagnosis is conveyed to a patient is can be differential depending on the doctor and the language, the words they use. It's not simply a scientific prescription, you know?
Oh, absolutely.
Talk to me about that. What good could come of better storytelling in medicine?
Yeah. To display this, I think I'm just going to give an example, because I think medicine is in this huge moment of reckoning right now where we're trying to decide, when we tell patient stories, do we include information about them that might bias the listener? So for example, way back in the day when, our grandparents were growing up, doctors felt quite comfortable when they would introduce a patient to another doctor. They would say, this is a 55-year-old Black man from this area of Atlanta, or this is a 60-year-old frail, disabled woman from XX. They were comfortable using these descriptors, which ultimately they knew would slightly change or majorly change the listener's thoughts about what the probable diagnosis was. Because in medicine, it's so complicated. We have rates of disease that are much higher in certain populations. We know this. There are disparities even in COVID, in all diseases. And so by knowing the race or the ethnicity or something about the background, census code, zip code of the person who has come in, you can probably, fit them into a category of risk for certain diseases. But then again, I think the medical generation that I'm a part of is concerned about this, because even if there are stereotypes and there are disparities, there's huge risk in premature closure, as we say, cutting off the listener's ability to freely think about what this diagnosis could be, and instead prematurely closing them off into one diagnosis. So for example, I was working in Germany over this summer, which is a vastly different place with different disparities and different healthcare challenges, which was part of the reason why I was so delighted to be there and to learn. And there was a patient who we saw who was a 55-year-old woman. And you can, by choosing the words to use to describe this woman, you can vastly change what the attending is going to think about what's going on with her. So you can say, there's a 55-year-old woman who came in complaining of vague body pain. She also showing signs of depression. This might make the attending think, this is a psychosomatic condition that this woman is dealing with. The pain that she's feeling all over her body associated with the depression makes me think that this is psychological in origin. I probably don't have to treat this pain with an actual like some sort of medication or pharmacology. I should probably prescribe, a therapist to this woman, and that's going to help with her pain. But on the other hand, if you include in the one-liner that this is a 55-year-old woman who is coming in from a household of violence, for example, or has a history of chronic kidney disease, had a history of child abuse, or including information about other comorbidities that might make more physical organic causes more likely, you're going to allow the doctor to think about those things too. So all to say that words matter. And I think words matter, especially in infectious disease, when we're trying to piece apart the cause of usually something quite mysterious. And so it's a challenge that I think will be endlessly fascinating in my career.
It sounds like the descriptors offered in the second scenario you mentioned are more person-based instead of class and meaning section-based or group-based. You know, it's not speaking about tribes you belong to, which statistically could say something or another about you and your likelihood of this or that. But it's speaking more about that particular person. It seemed to me from the alternative one-liner that you offered there.
Yeah. Yeah, it is. I think it is more personal, and ultimately it just takes more work. It's too easy to fit someone into a category, you know? And I think in our rapidly changing world, we have to let others describe themselves the way they'd like to be described. We can't just go in and look at someone and choose, this is the race that I will be applying to this person, this is the ability level, this is the sexuality. These things all, of course, change our comorbidities and our risk in this world, you know? But I think ultimately by letting people self-describe, we're making medicine, you're right, a much more individualized thing. It might be a little bit more time consuming than trying to just fit people into buckets and then assuming that what they have going on is related to their identity. But ultimately, you know, we all have an inner world going on, and it has nothing to do with the way that we present to the outside world. So nice to try to access that when we are with a patient, even though there is sometimes limited time.
So, Claire, one of the fields that you've worked most in has been gerontology. I hope I'm saying that correctly. The study of geriatrics and older adults. What was your foray into this world? How did you start getting involved in this part of medicine?
Yeah, yeah. I've been thinking about this a lot as I've been applying to residency, and people ask. I think because it's not very common to be interested in geriatrics. My guess is because it can seem to an outsider like a very depressing field. A comment that I get a lot is like, isn't that so sad? Aren't you sad all the time? Which is such an
If they could see your smile right now.
If they only knew. I find it to be the most, maybe not the most, such an optimistic specialty, and I'm never sad. Geriatricians often have the highest, you know, level of meaning in their work of any specialty, which is a metric I want to dig into a little more, but I'm not surprised to hear it. I think my interest in older adults stems from, you know, growing up, my fascination with these buildings that were combined nursing homes and preschools. And I found this to be quite a radical idea at the time, which looking back, I'm sad that I saw that as radical because in other countries it's normal. And in other countries, we keep our grandparents close as they age. We keep them in our homes with us. They are a family member. Something I've been disturbed by recently is how in the United States, we often treat older people as similar to people who are incarcerated, people that we want to keep far away from us so we don't have to look at them or face their issues, or deal with on a daily basis the pain and despair that they're experiencing. This bothers me a lot about prison in this country, that it is far away and hard to see on a daily basis.
By intention, right? It's something totally by design.
Of course. And I think similarly, of course, the situations are very different, but I think there are some similarities between those in nursing homes where we want to ignore the fact that we are treating the people who have, you know, contributed to our growth and have raised us. We're treating them so poorly in many cases, especially in their final years. So all that being said, I was so excited when older adults get to live among other generations in the richness of life that we all desire. I would hope that communities are all built this way. And after seeing that, I wanted to understand what the issues were in this field. And so I worked in Mexico for a while, where older adult care is very different. Similar to what I had mentioned earlier, older adults live with their family members. And so I worked in a public housing project for older adults in Oaxaca, Mexico, which is where some of my family live. And the older adults who were in public housing then were, by definition, the most vulnerable. They often had estrangements from family that they couldn't live with anymore. There were many victims of abuse in childhood, and they didn't want to be associated with their family. And so then upon returning back to the United States, I was just curious about the situation in the US. And I did a year with AmeriCorps in Wyoming at the Department of Health, where I was trying to answer the question of what are the barriers to aging in place for rural older adults, which it ended up being much more than rural. It was more so like a frontier older adult, which is such a unique experience.
What is that vision all about, aging in place? It's an ideal, I imagine, from the way it's described as
Yeah.
barriers to aging in place. What does that really mean?
Yeah, it's the aging in place movement is related to the age-friendly movement. And they both have the same sentiment at heart, which is how can we build cities with the infrastructure to support us as we age? Similarly to how do we build cities that are supportive to bicyclists? How do we allow for there to be bike lanes all around the city and there's safety and there's barriers and cars aren't going to get in your way? Parallel to that, how can we make it so cities are friendly to those who are aging, which, just to remind everybody, is all of us. We're all
From
aging.
the moment we're born. From the moment we're born.
We never stop. If we're lucky, we never stop, or at least for a long while. And I think the age-friendly movement is so exciting to me because not only does it help the people who you probably are imagining in your mind, a 75-year-old who has using a cane or a walker and needs various curb cuts and needs, if, for example, in Teton County, Wyoming, the way that they make their city age-friendly is that they have big barrels of canes on every street corner. So you can take one, use it as long as you'd like, then drop it off in the bin when you're done and go back to your home. And it makes it so there's this just more ease for people who might be unsteady mobility-wise. But what I wanted to say is that not only is the age-friendly movement helpful to those who are older in our cities, but it's also helpful to everyone else who might just have slightly different needs. Like I've personally seen a parent with 2 children in a stroller benefit greatly from an age-friendly community because it means that they have wider sidewalks with more space. It means there's more public bathrooms. It means that there's larger curb cuts and safer streets and less cars, less density. We all benefit from that. I think that there's a lot of truth to your first question in trying to fix things for those on the margins of our society, and then everyone else benefits. And I think my focus has been those on the margins of our society age-wise. So I think if we make the world a little better for those who are 90 plus, then we're all going to benefit from that.
In part because we'll be a little bit more excited about being that age, right? I mean,
Oh my gosh, yeah.
a deep fear about reaching that age because we don't really have too many examples of people who are thriving in their 90s. There are certainly examples. Some of us have, kick-ass grandparents, or at least share pictures of them on social media.
Yeah.
Folks who are living it up at that age, who moved to Japan and grow flowers, or who go on runs every day. There are certainly people who are living well at that age, but in general, we're not really taught how to age or how to plan for that phase. That was one of your findings during this year in Wyoming that you mentioned. You ended up writing a piece following that experience called "Barriers to Aging in Place for Rural Institutionalized Older Adults: A Qualitative Exploration," where you interviewed a good number of people who are currently in rural nursing homes or institutions. You'll correct me there, in Wyoming. One of the findings from this study was that folks were living in the present or had a present focus, which is supposed to be a good thing. At least I think many of us are trying to live in the present. It's a broad goal of most of us. And yet for these people, it ended up being something that was detrimental in the long run. Tell me about the difference there. So of course, living in the present is still the goal, but how is it not the goal as far as older age planning goes?
Yeah. Yeah, it's such an important question. And this was such an interesting insight to hear over and over from older adults that I talked to there. The big issue, I think, is exactly what you mentioned before, that we don't want to plan for when things get difficult, because oftentimes I think those conversations are nearly impossible We have to talk with our children, our adult children, about what we would want if we had such bad disease of the lungs that we needed to breathe with to be intubated. And none of us want to think about that reality or plan for that reality. So I think a big issue in this country is a lack of advanced care planning for older adults and with older adults. And something that I think we're lacking in is just the words to use to plan ahead. There are great groups around the country. One of them is the Conversation Project, which tries to give people words to use to help to plan ahead. But ultimately, the current state of things means that people are just hoping that they will continue to live at the same functional level for their whole lives. And then I think the implicit expectation there is that they will just fall asleep and they won't wake up one day. And they will never have increased needs. They will never need a nurse to come to their home. They will never find it difficult to walk a couple blocks and so might have to make other plans. We all should be thinking about that. And I do think, Dan, that if we are looking forward to those years of our lives, it'll be easier to plan ahead for them.
Practically speaking, how does one at any age plan for this phase without sinking into the depression that you're often accused of by those who are not in this field? How do we, if we have certain burial wishes, even, I mean, it's a valid thing to fantasize about, right? And we've all seen people be buried, and who hasn't thought about the way in which they'd like to ultimately rest? How does one practically, legally even, I might ask, convey that wish to someone?
Yeah, there's you probably won't be surprised. There are so many ways to do this. There are some that are more informal and some that are more formal. I'll start with maybe the more informal, which is purely having a conversation with your family members about the things that you'll want, not only with burial and your actual death and funeral and money that you might set aside for this, but also what you would want if you could no longer make decisions for yourself. Would you want to be fed through a tube, for example? Would you want to breathe through a tube? What sort of extreme measures would you want taken for you? And what do you want to happen to your body after you die? Do you want anything to happen to your organs? Do you want to donate them? There are various things that we can do with our bodies afterwards, after we die. So trying to be thoughtful about that, because ultimately, practically and medically, what happens when this happens, when someone has an event that drastically changes their life, who we turn to as the doctors taking care of them are their next of kin. So either their partner, their adult children, or their parents are the closest people. And those people often have equal footing in making medical decisions for a person if they haven't appointed a medical proxy. And so making sure that those people in your life, your partner, parents, and adult children, are very privy to your thinkings about this, which can evolve, That's the best thing about it, is that this conversation should be an ongoing one, because we expect that throughout our lives, we might change our opinions about what we might want. So keeping those lines of conversation open, I think, is critical. And then I touched on one of the more formal avenues, which is setting up a medical healthcare proxy, which is a great idea for anyone of any age. And what that does is allows for us, as someone taking care of you in the hospital, to have a phone number and a name to call for someone who you've kept up to date about what you'd want. There are other various people, like a legal proxy who can help, a healthcare power of attorney who can also be involved. You can fill out forms like the POLST form, which can it's similar to a DNR, but it allows for you to attest to a physician about what your wishes are at the end of life. And this is a legal document. So if you have an event at home and the paramedics come to your home, they know exactly where to look. It's either on the bedside table or the fridge is where everyone keeps their POLST form. And this says, I don't want to be intubated, I don't want anything to happen to me, or I want everything done to me to save my life. You can either also wear medical jewelry that is a practical way of helping with this. Some people even get tattoos that say, this is what I want. So then it's impossible to ignore. That's an extreme case, I think. But there are a variety of ways. I think the bare minimum is setting a healthcare proxy and making sure that there is someone in your life who feels responsible and up to the task of stating your wishes if you're unable to do so.
I love that you ended with that. I wonder what it's like, not just to convey your wishes to someone close to you, to next of kin, which is one important step, and a brave one, a peaceful one, I imagine. Also, just to plan for aging, which is the ultimate recommendation here. How does one serve as a proxy, though? It seems like a challenging position as well. You mentioned that our desires can change over time as far as aging goes, and there's a lot of doubt, I think, sometimes on the part of proxies regarding the true force of someone's wishes prior to being in a moribund, in a deathly situation.
Yes.
It's hard to be the person who then says, nope, this person who has entrusted their life with me has told me that they would like that tube removed, or that they would like to not be sustained in this stage, in this state. It's a hard place to be in. Is there? I'm not sure if we're ever trained in that. What does it look like to be a good healthcare proxy? Can you reject the role? Tell me about that a little bit.
Yeah, it's a big thing to put on someone we love, isn't it? It's a hard thing to
Really?
ask. Yeah. So much comes to mind with your question. One thing is that I think as people who are younger, I think, a lot of people among our age group are going to be asked to step up in this way if we haven't already. One thing we do in medical school is one assignment that we have is to fill out this paperwork with our parents. So then we know what happens with patients. And we also, I think, feel a sense of contentment. I certainly do. I have these documents in my dresser at home, and they say exactly what my parents would want at the end of life. I find, when I'm asked, like, what would you save if there was a fire? There are various things that I would try to grab from my bedroom of sentimental value. And I would also grab these pieces of paper, which I sat down and filled out with my parents for hours, and it felt like a hard but important thing. And I think it felt really clarifying because it takes a lot of the weight and the burden that you're describing off of this. If, God forbid, there was something that happened to either one of my parents, I think we often see in the hospital this situation where it's an adult child who feels guilty or sad and says, I want everything to be done for my parent. But if the parent has clearly stated, I don't want this, it's no longer a decision that you're making. You're just making the decision that they would have made if they were able to. So it's not you making the decision. You've had this conversation. You know exactly what they would want. I think it takes a lot of the guilt and burden off if you had the sort of foresight and put the time in advance to make this happen. To respond to your question about whether you can reject this, it's interesting to see how it plays out in medical families who are very aware of how this can go south and trying to set themselves up.
You are in a medical family. It's worth saying at this point, right?
I am in a medical family. Yeah, I guess what I mean is someone who's seen so many sick and dying people that they have quite well-informed opinions about what they'd want for themselves because they've seen patients where they realize, I would not want that for me or a family member. So I'm going to try to prevent it as much as I can. I have a friend in medical school who is married, but who has made me his healthcare proxy because he would like to spare that role from his wife, which was sort of a surprising conversation. And also one that I think speaks to your point of him feeling like, I can't expect you to make a hard decision when you are so sad too. I can't expect you to say, no, we've done enough. Like, he will be happier if we stop going to all these extreme measures to save his life, for example. And I think sometimes we can better trust perhaps our friends to sometimes honor those decisions, but it's such an individual situation. So
it sounds like a lot of this training came either through your parents, both of whom are doctors, which is
yes,
crazy.
they are.
A lot of it came through this gift in your education. I understand that your education at Harvard, which is where you went to medical school, uh, did not include a lot of this palliative care education, or it was incomplete. You wrote about this along with your co-authors in a letter, what I interpreted as an open letter to the Liaison Committee on Medical Education. You wrote
Mm.
a piece to them called A Good Death for All, the need to teach racially sensitive end-of-life care. And one of the questions you ask in that piece is, how should our medical school curriculum prepare us to provide our patients with equitable and culturally humble care, not only during the prime of their lives, but also during their final days, which is not to say death, right? This is my words now. It's not to say death, it's to say dying. How can a medical education better prepare students for this?
Yeah. To answer that question, I want to just say how a medical education can poorly prepare its medical students. And one way is by repeatedly telling us that the end of life is the most expensive. This is something that comes up often in med school, is that your last weeks and months of life are the greatest Medicaid and Medicare expenditures of your entire life. This is an interesting point in my mind, the financial one, because I think we often like to escape from it as doctors and not think about how much that MRI is going to cost, and not think about the medication, but just, go based on the science and try to just prescribe evidence-based medicine to our patients. But ultimately, I think the fact that end of life is so expensive, which is a fact proven time and time again, is also another piece of evidence towards what we all wrote about in that paper, which is that there's desperation at the end of life, both personally and medically. I think we often feel that we need to go to extreme measures in order to save someone. And we have to always check about whether that's what they want. Something that we wrote about in the piece is that these wishes at the end of life vary greatly by race. We see the rates of hospice utilization to be much lower in the Black community and other communities of color than it is among white people. And that's troublesome in a lot of ways, one of which is that people who enter hospice at the end of life, their family members are far happier with the death process than those who enter the hospital and die in the hospital or in the ICU. So we, of course, want those bereaved family members to be at most peace as possible. And for that reason, we want to advocate for hospice utilization for people of all backgrounds.
It
But
sees dying
ultimately,
as a more than just individual. The person dying is not the only one affected by that process.
yes. And this is a critical insight that I didn't understand until later, which is that to measure the success of someone's death, you can't talk to the person. You have to talk to their family and you say, how was that for you? What could we do better? And often in medicine, the patient themselves might be asleep or in surgery, and the real people that we're caring for are the worried parents or the worried adult children or the worried spouse. And it's no different here. So I think that because of, and I just want to touch on this because I think it's so important, is that because of this justified mistrust in the medical system, it means that for some patients that we see, most especially in Black patients, they might feel that when a doctor says there's no more that we can do for you, I think you should enter hospice, they might feel like, I don't trust him or her or them. I don't trust that they're telling me the truth. And so I want to stay in the hospital and I want to fight this. And that means that, of course, expenditures are higher, as they always like to say, but it also means that rates of hospice admission are probably lower, or definitely lower. And that's something that we have to work on culturally. That won't be something that's easily solved.
Go out fighting is the expression we like to use. I think
Yeah.
newspapers have slowly moved away from language such as fought a hard battle with cancer or with an illness. There is a lot of, the US is a very belligerent country in general, and I think we include that attitude in the ways our bodies deal with ailments and with conditions. We are fighting them We
Mm.
are at war with our with the things that want to kill us. Uh, it suggests that there's a piece I hear you saying in at some point in the process, which is a hard point to determine, and understandable that folks might want to gather a couple different opinions. But if every doctor is telling you don't fight, uh, enjoy the rest of your days, it might be because that is simply the best use of your life right now.
Yeah, I agree. I agree. It's a lot to ask. And I personally don't have that history of mistrust. I don't understand it as personally. So I can't blame people for feeling that way. I I find it so interesting what you're saying about our changing language in this country. And I'm glad that you still use we when you refer to the United States, even though you're far away. Um, I think that what I wish people saw is that the diseases that we hospitalize people for nowadays are less so external insults to ourself. You know, way back when people were mostly dying of infectious causes like cholera, which is definitionally an external thing. You know, it's a pathogen, it's a bacteria, it's a virus, whatever it might be, coming into your body system and attacking you. It makes sense that we use that language. But nowadays, what we're dying from is mostly heart disease, it's mostly autoimmune conditions, it's cancer. These are not external factors. These are our own bodies often fighting against themselves. And so I think that's what makes it especially hurtful to say someone's fighting cancer or fighting lupus or they're fighting heart disease. Often these are diseases that came from a life lived in a fundamentally unhealthy society, an unhealthy society in the way that we've systematically set up things to be hard for people, especially people, of certain racial groups and people who have unstable housing. So I think to blame them for the illnesses that they develop because of a society that has not set them up to be healthy, set up any of us to be healthy, I think is especially hurtful. So I'm in agreement with you that it's a good thing that is hopefully less common nowadays.
What do you understand by the word doctor?
My first thought is leader. I think that's what perhaps sets a doctor apart from um, other careers in the medical field. Because to be a doctor means so much more than I ever knew. There are doctors who work 100% clinically, and then I'm seeing there are doctors that work at these governmental agencies and they don't see individual patients, but they see our whole country as their patient. And so they're doing research with that in mind. And so I think what is shared among them is leadership and real accountability. They feel their work and their mission on this earth is to try to advance human health in however they see fit. And I think that there is something quite shared among doctors, and that sometimes people feel that they try to be a physician dash something else. So in my mind, I always liked the idea of being a physician dash writer. Some people like the idea of being a physician advocate or a physician senator, a physician social worker or a physician researcher, physician teacher. So there are so many ways that you can do this, and that's shared among many careers in the medical field. I feel like being trained as a physician is such an investment in me, and I am grateful for that every day, to get to learn from these smart and kind people and to just try to surround myself by enough of them that they rub off on me a little bit.
You certainly, at least to me, make more complex the definition of doctor. Uh, I I think that unfortunately many of the examples that so many of us meet throughout our early lives don't necessarily, you know, contain a lot of love or
Hmm.
emotion, not in the ways that you transmit them through your person and through your thoughts on the role of the doctor. It's inspiring to think that there is a movement of younger doctors who, not to class all older doctors in a category. I'm the son of one, and as are you. They're not all bad, but there's certainly something new in the youngest generation of doctors. It's evident in you, and it's evident in so much of what's coming out of that field these days.
I agree with you. I am hopeful, and I see my fellow medical students who are identifying issues both within how we take care of patients, but also in how we take care of ourselves. I hope that if physicians, as we get older, become increasingly, and this is happening, becoming increasingly diverse, increasingly representative of the country. I hope we look like the country that we're serving and we look like the communities that we're serving. I think that's proven to make for a better provider. And I also hope that our generation continues to remind ourselves of the anger and the frustration that we had as medical students. I came to be a doctor in the age of the pandemic. I learned anatomy over Zoom. They held a computer above the cadaver and we watched as things happened. It was impossible to ignore the fact that there was a global pandemic going on. But I also came of age as a doctor during, this arising conflict in the Middle East, in humanitarian issues in Yemen, in like a measles outbreak there. So hopefully this generation of doctors can both remind our older generations and also continue to remind ourselves that this anger is justified and we need to follow it and listen to it.
Yeah, it's going back to the point you made earlier about wanting to help an individual, but also seeing that they're part of an ill system, and how does one, as a doctor, address both levels of that? You've traveled a lot and worked in different places. You mentioned in this call Germany and Mexico. I would think we can add Uganda to the list as well. Is that right?
I haven't been to Uganda. I would love to go.
Okay, so let's not add it. Let's not add it to the list. In any case, you've seen medical systems in many different countries, in many different places. In general, I think the response that folks who see medical systems in other countries have regarding the domestic U.S. system is one of dismay and frustration around its costs, especially around its costs, and around some of the demeanor in it. Do you find points of inspiration in the current U.S. medical system, something that you have found to be stronger, but we don't need to do a comparison with systems in other countries?
Yes, I definitely have. I agree with the points that you're making about the limitations of our healthcare system. And also, I think the beauty in the American healthcare system comes from the diversity of the patient groups that we are able to serve and care for. The times that I've been most inspired by working in the American healthcare system have been moments where I've been working in primary care, and I see the level to which these individual primary care clinics rise to the needs of their patients and rise to the individual needs of their patients. For example, working in Boston and Cambridge, there are large numbers of people who are originally from Haiti and originally from Brazil and the Azores. And so that requires either very robust translation services into Haitian Creole and Brazilian Portuguese, or taking the time, as many providers have done, to learn those languages. And to then
And as you do as well.
Well, I mean, I work on my medical Spanish all the time, and it's, of course, also useful in Boston. And I'm inspired to continue to work on that language because of the people around me who I see taking the large amount of personal time investment to try to speak to their patients in their own languages. I think that's only one example of the ways that I think primary care in this country is leading the charge in increasing health equity, and hopefully all specialties will follow.
Claire, is there anything I haven't asked you? Anything you'd still like to say?
One thing that I've been thinking about to respond for probably like a third or fourth time to your question about what is true, is one other thing that I've definitely realized recently, and it feels all the more important as we move to new places in our lives. But it's just that we become the people we surround ourselves with, and that's why I feel lucky to know people like you, Dan. And it's also why, in response to your question about what the value and joy and leadership of the American healthcare system is, it's why I feel such a pressure to go to a residency program that takes the culture of its program seriously. So then you do, train in a place that agrees with your values, and you're not constantly fighting to make yourself heard and to affirm what you think is important. So I feel like in friendships, in personal life, and work, I am always amazed by the power of the people that you spend the most time with, and how we sort of come to look like them, whether we like it or not.
Yes, certainly. The setting in which we are educated then has direct impacts on the ways in which we exercise that education later. I love that. Mm-hmm. Claire, a couple lightning questions here.
Mm.
A skill you're currently working on.
Working on? Not really a skill, but I'm collecting cassettes right now. I'm working on my discerning eye.
A favorite way to relax?
I'd say a run in a new city in which strangers become friends.
If you could attend any historical event, which would it be?
Oh. Gosh, Dan, so many.
You only get one time travel trip.
A historical event.
I'm going to bring in the lightning countdown timer.
Yeah, okay. I think I'll say the founding of St. Louis as a city, and especially of Cahokia Mounds right nearby. I would have loved to see how Native people and St. Louisians came together and sort of honored that land.
That was a response worth waiting for. A book that left a lasting impression on you.
Harry Potter for sure, but also anything by Toni Morrison, especially Beloved.
Something you're grateful for?
My parents, my grandparents, and all the time and energy I have in my life right now.
Is there something people get wrong about you?
I would say no. I think I'm generally an open book, actually.
And lastly, a song or album that you would recommend?
I love the song Voy a Valparaíso. It's like one of my favorite songs to listen to, and I'd love to think about Spanish and to practice thinking in Spanish, but I am feeling a little calmer. It often lulls me to sleep.
Voy al paraíso, like I go to paradise?
No, the last word is Valparaíso, the city in Chile.
Oh, the city.
Mm-hmm.
The city.
I was just listening to it on the way here.
That's beautiful. I'm going to look it up. Thank you, Claire, so much for being here. It's been a pleasure.
Thank you for having me, Dan.
Thanks for being here. If this conversation resonated with you, consider reviewing Therapy for the World or sharing the link with someone who might appreciate it. Until next time, speak with care and listen deeply.